Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another CaSMO webinar. This evening, the Canadian Skin Management and Oncology Project will be presenting practical primers for cancer patients and survivors on the management of cutaneous toxicities associated with immune checkpoint inhibitors. As speakers this evening, we have Dr. Marcus Butler. Dr. Butler is medical oncologist at the Princess Margaret Cancer Center, Melanoma Skin Oncology, Site Lead Adoptive Cell Therapy, and Tumor Immunotherapy Program. We also have Dr. Joël Claveau, who is dermato-oncologist, Melanoma and Skin Cancer Clinic, Centre Hospitalier Universitaire de Québec, Hôtel-Dieu de Québec in Quebec City. We would like to thank our sponsor, La Roche-Posay, for making this educational event possible. Before we begin, a couple of logistics tips. First, if you are having issues hearing the webinar, you can listen to the presentation using your phone. Just select phone call in the audio pane, and a dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your web browser following the webinar. If you could please fill it in for us, we would greatly appreciate it if you could send it back. And finally, within 1 to 2 days of the webinar, a recording of this program and a certificate of attendance will be emailed to you. Again, if you want to submit questions, just use the question chat pane on the right-hand side of your screen. So without further ado, I will pass the floor virtually to Dr. Claveau.
Merci. Thanks a lot, Roxanne. Thanks everyone for attending tonight. Thanks to La Roche-Posay for putting this event together, and happy to participate. I'm a dermatologist in Quebec City, working with my oncology colleagues. Okay, so before we start, I would ask a few questions. We will ask the question to start and then come back with the question at the end. The first question is, what is the less frequent side effects of immunotherapy in cancer? Thyroid dysfunction, skin eruption, colitis, cytopenias, pneumonitis. Less frequent, people answer skin eruption. Great, we'll see later on. Back up, I think we skipped a question. True or false? Pruritus with primary skin lesion is a frequent side effect of immunotherapy. True or false? Great, 80% through. Polling question 3. What is the most frequent cutaneous side effect of immunotherapy in cancer patients? Lichen planus, psoriasis, morbilliform eruption, bullous pemphigoid, or vitiligo? Morbilliform eruption, we'll see later on. Well, last pre-test question. What is the most important therapeutic option for cutaneous eruption? Systemic steroids, topical steroid, stop immunotherapy, immunosuppressive treatment. Topical steroids. Great. Let's see later about that. Okay, so we've done the 3 and 4. So the plan for today is to review a little bit what is the CaSMO project and update where we are right now. Of course, tonight we will concentrate on the cutaneous reactions related to immune checkpoint inhibitors. You will see with my colleague Marcus' presentation that this is a breakthrough in oncology, actually probably the biggest change in cancer treatment for the last 10 years. And of course, those treatments are not without side effects, and we have a lot of cutaneous reactions. So we'll review this challenging reaction and try to present a primer in the management of those cutaneous reactions, including good diagnosis, find or let's say try to prevent or diagnose quickly a severe reaction, and then management to give better quality of life to the patients. So the CaSMO group is a Canadian group of oncologists that really in this project we wanted to develop an approach to improve cancer patient and survivor their quality of life, giving them tools to prevent and manage cutaneous toxicities from various treatments. We've developed different algorithms to diagnosis and also to treat cutaneous toxicities, including chemotherapy, radiotherapy, targeted therapy. Those algorithms are developed for healthcare provider and involved in oncology care, either physician, nurses, pharmacists, or other providers. And really, we want to give a practical approach, especially in this project tonight. We're going to talk about immunotherapy-related skin toxicities. Sorry. Clicking too fast. Small. So we have published already in Skin Therapy Letter a couple of papers. First was really the role of skincare in oncology patient, not only treatments, but also the importance of gentle care to the skin, moisturizing, sunscreen. This is very important to the patient. We will see tonight. Often women maybe are more likely to take a better care of their skin, but this is very important in the management. And then we really jump into like related skin toxicities and try to develop more specific algorithms, as I mentioned, for chemotherapy and also for radiotherapy, radiodermatitis. So for each of those projects, we develop our consensus document or using a modified Delphi approach. Could review the literature, preparation of the first draft of the document. In the case of immunotherapy, we have discussed those paper in a group later on and develop a manuscript with reviews and publication in Skin Therapy Letter. So if we do a literature search on those topics, in the last few years, we have seen a booming number of publications on immunotherapy and side effects. As I mentioned, it's a big change in our practice. And for our research, it was really concentrated on Google and Scholar and also PubMed. Out of 106 papers we reviewed, we include 94. 25 were systematic reviews or guideline paper, 29 clinical studies, 14 epidemiologic, and 16 reviews. Really, we wanted to develop approaches for the most common immune checkpoint inhibitor-related toxicities. There's a big group of toxicities. We concentrated on isolated pruritus, psoriasis, lichenoid eruption, eczematous, morbilliform, and also bullous pemphigoid. Even though it's rare, it might be more problematic to our patient and has been described with with the use of anti-PD-1 and anti-CTLA-4 medications. This is the paper that's going to come out soon on this topic. So without further ado, I will introduce my colleague and friend Marcus Butler, medical oncologist working in Toronto. And Marcus gonna talk about the general treatment with immunotherapy and also the management of side effects. Hello, Marcus.
Hi, thank you, Joel. Okay.
So if you click in the middle of your screen, it should work. There you go.
Okay. So I'd like to review the challenges of treating cutaneous toxicities associated with a new class of drugs that we use for cancer called immune checkpoint inhibitors. We're going to first just review a little bit about the burden of cancer in Canada, discuss immunotherapy and the mechanisms of action of these agents and their indications, and then talk about the importance of collaborating with our dermatologic experts in the management of patients who develop toxicities. And then Joel will review some of the specific toxicities that occur that require expertise of the dermatologist. So cancer is a growing and continued problem in Canada. Over 200,000 people will be diagnosed with cancer in Canada per year. And more than 80,000 people will die of cancer each year in Canada. In the past, cancer was associated with men more than women, partly because of smoking and lung cancer. Unfortunately, women are now catching up, and there is parity between the sexes in terms of diagnosis of cancer. And while smoking has significantly improved the lack of or decreased smoking has improved the incidence of lung cancer, it's still a very common disease, and there are just as many lung cancer patients as breast, colorectal, and pancreatic cancer patients. And this is important in terms of immune checkpoint inhibitors because anti-PD-1 therapies are used frequently with lung cancer, not just melanoma and some of the other less common cancers. So the mainstay of treatment for patients with cancer still includes chemotherapy, radiation, and surgery. There have been some significant developments over the last 10, 15 years, such as tyrosine kinase inhibitors, or something called targeted therapy. In this graph, you see a melanoma cell with a BRAF inhibitor, which is a type of targeted therapy. It's a pill that you take that has a high chance of helping patients with melanoma. There are also other tyrosine kinase inhibitors that are used in lung cancer. And that's the other significant development over the last 15, 20 years. But immunotherapy has been quite an amazing development. First approved in 10 years ago, 2011, 2012, the CTLA-4 blocking antibodies were found to have efficacy in melanoma. And then shortly after that, the anti-PD-1 drugs showed activity in diseases like lung cancer and melanoma. And that's really where there was really an amazing explosion of these agents in management of patients with cancer. There are many different types of immune modulating targets that are used in the treatment of cancer. On clinical trials, the targets that you see on the left, the activating antibodies are used. On the right, in Canada, we have agents that target CTLA-4 and PD-1 or its partner PD-L1. In the US, and soon I suspect in Canada, we'll have an anti-LAG3 that has shown efficacy in melanoma and other types of cancers. So there's quite a lot of excitement and use of these agents in treatment. As I mentioned, ipilimumab was the first immune checkpoint inhibitor. Pembrolizumab, nivolumab, cemiplimab are anti-PD-1 antibodies that are approved and used in patients with cancer. So that arrow above is for the CTLA-4 and the one below is anti-PD-1. As you see on this table, there are multiple agents that are being used in the clinic. All the agents that you see in the middle column have been approved and are in use in Canada, except for tremelimumab, which is not approved in the US or Canada. And as you can see on the right, there's a list of multiple different types of cancers that are used with and targeted with these agents. There are additional agents not listed here that are being used, but essentially almost every single type of cancer has at least a subtype which can be used, treated with immunotherapy, and that's great for patients because we do see durable long-term responses. It is, however, means that we are dealing with side effects that are unique to immune checkpoint inhibitors. Again. As I mentioned, the mechanism of action of this agent is that these agents are that we are disrupting part of the immune system's regulatory system. The anti-PD-1 and anti-CTLA-4 drugs are interrupting a suppressive signal on T cells. And as a result, when we interrupt that suppressive signal, we allow a pro-inflammatory response to occur. And that's great for inducing an anti-cancer effect, but it's unfortunate in that some patients, depending on their particular immunologic makeup, may develop side effects that involve activation of the immune system and targeting of normal tissues, resulting in side effects. As you can see on the right, there's like almost every single tissue has the potential for developing a side effect. If we start on the left side, we see cytopenias, which are very uncommon. Pneumonitis, 5% of patients will have pneumonitis with anti-PD-1. Thyroiditis is more common. It can occur in about 10 to 15% of patients. Encephalitis, hypophysitis is less common. Uveitis, a little bit more common. Rash is actually one of the more common toxicities that occur. So some sort of skin issue is very common with anti-CTLA-4 and anti-PD-1 drugs. Colitis, just as to mention, is a common problem with anti-CTLA-4 and occasionally with anti-PD-1 drugs. But in any case, the mainstay of treatment for patients with these side effects is to downregulate the immune system by administering systemic steroids. And there is this loose association between these side effects and overall treatment benefit. I think it's because a competent immune system can have an anti-cancer effect as well as an autoimmune effect where the immune system attacks normal tissues. But if you do a head-to-head comparison, and we can only kind of get a window into this by looking at real-world evidence, it does appear that patients who have similar toxicities, but where the standard practice is to give more intensive systemic steroids, those patients don't do quite as well as the patients who have limited amount of systemic steroids that's given. That makes sense from an immunologist point of view because steroids are immune suppressive. But in any case, when you have a severe toxicity such as the myocarditis that's shown here, you have to give everything you can to downregulate that immune response so that you can have the patient survive the side effect. And yet we will have patients with grade 3, grade 4 toxicities who make it out the other end and their cancer melts away and is gone. So we accept the risk of these toxicities. We just need to figure out better ways to manage the toxicities when they do occur. In terms of the timing of toxicities, the graph on the left is a graph that's often shown. That's derived from anti-CTLA-4 data. You can see that rash and pruritus is the first toxicity that can occur, often after just one dose of an anti-CTLA-4 drug. Other toxicities come up a little bit later. But as you see on the right, this curve shows in the red IPI plus nivolumab combination toxicities. You can see the toxicities occur very early, but also can occur much later, a year after for initial treatment after the patient goes on to therapy. And then anti-PD-1 drugs tend to be a little bit later when the toxicities occur. But as you can see, skin can occur at any time during the treatment, up as long as the patient's on treatment, up to a year or two that patients will often be on treatment. So skin is often a toxicity that we are managing. So in terms of the skin toxicities, which are commonly occurring, we see a diverse autoinflammatory spectrum of diseases. You can see pruritus and xerosis, eczema, lichenoid eruptions, psoriaform eruptions, bullous pemphigoid. Vitiligo is also very common in the melanoma patients where a robust anti-melanocyte response results in an anti-tumor response as well as vitiligo. Now, this is a useful slide for dermatologists in the audience to see, because this is the sort of thing that we will have in the package insert for patients that we're treating with immune checkpoint inhibitors, because that's really the way the clinical trials were done. The clinical trials were not nuanced. If you had more than 30% of your body involved with a skin eruption, then we would start topical treatments, which we typically would use briefly and then really add a lot of systemic steroids to try to control the eruption, because we were always very concerned that there would be some sort of toxicity that would get out of hand. And we did learn with these drugs that if you ignored colitis and other sorts of toxicities, you could end up with severe organ damage, and therefore we really got on top of the steroids early. In my work with dermatologists such as Joël Claveau or Maxwell Sauter at my institution, I've learned that effective treatment can be obtained by giving adequate topical steroids and avoiding systemic therapy, and then we often are able to continue treating patients with their immune checkpoint inhibitors. But this slide is very useful for the audience to be aware that a lot of times our medical oncologists are seeing guidelines that suggest very vigorous systemic steroid treatment, which many of us are believing and feel is an overcall and may be unnecessary. And we need to learn to treat patients a bit differently, and that's one of the purposes of this program. So managing skin toxicity is very important for our patients. This is a slide that's applicable to immunotherapy, but as you'll see, does review things that are applied to chemotherapy and radiation as well. But just to keep in mind that for skin toxicities, especially for toxicities which, from the medical oncologist or nursing or dermatologist point of view is really not that important or life-threatening. But skin issues for patients can often be a major source of anxiety and have a negative impact for patients. I'll be honest with you, when we're sitting down with our patients with melanoma and we review the potential toxicity, we mention rashes, but we're really focused on making sure the patient understands that they could die from something like cardiomyositis or pneumonitis that's not managed and kept in keeping us in the loop and intervening appropriately. So because the patient is hit with this diagnosis of cancer, and now they're going to start this new treatment, and I can give them a laundry list of all the potential toxicities that might occur, and I say, but don't worry, the vast majority of these won't occur. A lot of times patients are not aware that their skin may be affected, that it's not something that they take in, and then they're quite surprised that the toxicities, the skin rashes which do occur, are more common than you would expect. It reminds me of a patient that Anthony Joshua had years ago when pembrolizumab was first starting. And in that case, the patient read on the consent form that vitiligo could occur. This woman who had very bad melanoma was considering not even taking the treatment because of the risk of vitiligo, because she didn't want to look like Michael Jackson. And then she ended up taking the treatment. Unfortunately, she did develop some vitiligo, but it wasn't a very severe toxicity. But that really illustrated how important maintaining beauty and skin health is for patients. We definitely are seeing that if for immunotherapy, while this slide is focused on chemotherapy, where patients will decline chemotherapy due to hair loss or find that chemotherapy related alopecia is a very traumatic side effect of treatment. Skin with rashes, which can occur and can be disfiguring, are a major issue and might result in some patients or a physician choosing not to proceed with treatment. And then psychological well-being is important for us to keep in mind for patients so that we can help manage their skin toxicities effectively. And if we are successful in controlling these side effects without needing systemic steroids and all of the toxicities associated with that and impact on efficacy, hopefully we can get more treatment adherence and better outcomes from our therapies. So 34% of patients on chemotherapy reported dermatologic AEs is the most important issue during treatment, and I think that continues to be true for patients with immunotherapy. Certainly the benefits of treatment outweigh the side effects. When patients have scans that show that there's shrinkage of tumor, they're often willing to deal with the toxicities, but getting on top of them is very important for patients' quality of life. And what I've found is that understanding some of the subtleties of management of the skin toxicities is very important. I'm learning from my colleagues in dermatology how to manage these toxicities so that we can get on top of things quickly. We're often faced with dermatology consultants who are overworked and unable to see patients right away. But if we can perform a biopsy and initial assessment, we can really improve the patient's quality of life early. What Joelle will mention is that there are some difficult cases that require a dermatologist, and working with the dermatologist to learn how to manage the less difficult cases, I think, is very helpful. And adequate management is important. As we mentioned, it's important for quality of life and in treatment coherence. If we can identify the skin toxicities early and manage it, we can avoid having severe worsening that requires cessation of treatment. And now I will hand over the mic to Joelle, who will review with us additional specific issues with skin toxicities. Thank you.
Thank you very much, Marcus. Was excellent review. Maybe in the chat, if we have a few questions directly to your part, might be a good time. But really, I think you made an excellent overview of the importance of immunotherapy in cancer patients. Of course, if you see the big picture, I think you would probably have more patients on immunotherapy for lung cancer than melanoma. Melanoma, as dermatologists, touching us more. But if you just get the general consult for a cancer patient for skin rashes associated with immunotherapy, we'll see a lot of lung cancer and also GU. So this is really not only the business of skin cancer, but also every oncologist. Okay. So let's see how we could address those eruptions and manage them. I'll try to review a general approach to those eruptions, a little bit touching on the incidence of the immune-related side effects according to which treatment the patient is receiving. We will make an overview of the most frequent cutaneous side effect and talk about management. This is a small, interesting algorithms we've developed with the CaSMO group. Really, I think actually something we're probably missing even now, and we have to probably emphasize is probably the patient before he starts the treatment should be educated about the importance of skin care. I actually saw a patient today, a family member of mine treated for breast cancer, and really she was so concerned about the eruption she had on her skin. She said, I'm not gonna go and eat with my friends because they think I'm gonna be contagious with what I have on my skin. So really, it's a big psychological burden on them, and it really, you mentioned it very clearly, Marcus, that it's very important for quality of life. So I think when you give the diagnosis of cancer, often metastatic, and you will start the treatment, patients are stressed, they have so many things to think about. So maybe it's important that we have different visits with them. We need the support of our staff with pharmacists, nurses, other caregiver involved in the care of cancer. And maybe it's time at the next visit to say, okay, you will have problem with your skin. It's good you avoid strong soaps. It's good you avoid a very long and warm bath and shower. Moisturize right after a short shower, and use sunscreen. So really, it's important from the beginning. Any cancer treatment you receive, either radiotherapy, chemo, targeted immuno-hormonal therapy, bone marrow transplant, will have skin side effect. Might be a reason to stop treatment, might be a reason, as we say, not to embark on the treatment. So when the treatment is started and we have a skin side effect, I think the first goal for every physician, every caregiver, could it be a severe one? So that's why we put in our algorithms right in the middle is what are the signs of a severe skin eruption that can really harm the patient, maybe lead to death. And really those signs we have there, we'll repeat, is fever, skin pain, blisters, and mucosal involvement. So that's really for every actually drug eruption we have the dermatologists and the colleagues, we're asking about those severe sign, and when it is the case, it's time to talk with the oncologist and maybe stop the treatment and really react quickly. If it's not with severe signs, then you may have a more simple approach, as we mentioned, moisturize and topical steroid, and then we reserve the difficult cases to dermatologists, because dermatologists don't want to see all the skin rashes associated with cancer. So really try to pinpoint and look for the severity sign, and then try to manage general eruption and look for more specific sign. If you have a good management of the skin eruption, often you will not have to stop the treatment and you can continue. Sometimes we hesitate, the skin rash is more severe, so sometimes we will just postpone the treatment and be in collaboration with colleagues to decide when we can resume the treatment. So again, I want to emphasize, like we've done in the CaSMO algorithm, you see a skin eruption, it's beginning to improve. Every day the patient is calling the nurse, and we are stressed about that. So do we have signs of severity? And those are fever, bola or blisters, skin pain. Look for the mucosa. Don't forget to look in the eye, the mouth, genital mucosa. And also, finally, when you do the blood testing, do you have eosinophilia or abnormalities for liver function test? Really, this is the 5 boxes that you have to remember. It's always the case with any drug eruption we have, but especially with immunotherapy, this is the approach we have. This is a nice table summarizing the main treatment. So CTLA-4 is ipilimumab, used mostly in melanoma, but also in other cancer now, like lung cancer starting to be used. You see at the beginning, we had about 24% skin rashes. Anti-PD-1, 54, but if we calculate pruritus and some dermatologic review might be even higher. But when you look at combo therapy, which is often ipilimumab plus, let's say, nivolumab or pembrolizumab, you have a double of side effect and often more severe. If you type immunotherapy and skin rash or skin eruption, you will see a huge number of publications over the last 5 years. This is an extensive list of every skin condition that have been described, even like rare condition like Grover's disease, dermatitis herpetiformis, vasculitis, connective tissue disease, paniculitis, I've seen that, lupus, radiosensitivation, etc. But really, we don't want to cover everything tonight, but really concentrate on the main one. What you see, you have to be careful, and as mentioned, as Marcus mentioned, the side effect often is the first one at the beginning in the first few months, but sometimes can happen even at the end. In melanoma, we give adjuvant therapy for melanoma for 1 year, and I've seen a patient developing bullous pemphigoid 3 months after stopping the treatment. So it's really unpredictable, and you have to keep an open mind to find and make a good diagnosis. Biopsy. So Marcus mentioned biopsy. Dermatologists, we use biopsy, but we don't need all the time biopsy. But if you look at the big category compared, let's say if you want to classify by histology, you have the inflammatory group, which often is a reactive reaction, can be lichenoid or psoriasiform. You really have the big group of immunobullous disease. The classic manifestation is bullous pemphigoid. Sometimes can alterate only the epidermis, like in Grover's disease. and you can have a really reaction to the melanocyte like we do have in vitiligo. But most of the skin reaction, when we do biopsy in immuno-related eruption, we have a lichenoid reaction. I must admit that the skin biopsy is not mandatory for diagnosis. Sometimes we have a classic presentation, but we do a biopsy for more rare presentation. So I think which is often not very well documented and sometimes overseen is the fact that we have a lot of pruritus, can be up to 50% of the patient with pruritus. You don't have primary skin lesion. What you see is excoriation, especially in the winter time. So I think it's good. You seen this patient was treated with pembrolizumab and binimetinib. This is a treatment, a combination of treatment used in this case of a small cell lung cancer. I think this patient could have been instructed to use moisturizer even before starting the treatment. So a lot of skin excoriation. You have to rule out maybe scabies, but in that case, you didn't have any primary disease. So isolated pruritus, often you see in the beginning it's written moisturizer and sun avoidance, but I think the first line recommendation, we should even say decrease soap, less long of a bath of a shower, avoid maybe wool, cotton clothing, and then moisturizer. Of course, you can add, let's say, antihistamine, and sometimes you will use products like pramoxine, but I would think the most important is decrease irritant and moisturize. I would say the most frequent eruption is morbilliform, which is the classic maculopapular eruption. Some people like to use this term, some others don't like, but you have those papules, they are not lichenoid, they're not psoriasiform, they're widespread on the body, can be very itchy. And this is like the most frequent eruption with immunotherapy, and I think could be managed carefully, like appropriately by a medical oncologist without asking us consult. In that case, of course, you look in the eye, you look at the mouth, you have no mucosal involvement, you don't have any vesicle or blister, no pain. This is pruritic, but not dangerous, not life-threatening. So really, this is a good example where your good topical care can avoid stopping immunotherapy. Can be mild, can be severe. I would think it's underdiagnosed. Actually, saw a couple of patients this week coming for their follow-up, and I said, "Oh, what about your skin?" I said, "Oh, my skin is okay. I'm just itching here and there." So they had a little bit of maculopapular rash, not treated. So again, I reemphasize the importance of moisturizing and give them a topical steroid if it worsens. Really, we will need systemic steroids. So you see, in the general algorithms in the clinical trial, you just have skin rash, and it's no specific diagnosis. So in that case, you have to recognize just a morbilliform eruption. But then I've seen those cases. This is a classic case of a lichenoid eruption. It looks like lichen planus. You can have in the mouth. You do a biopsy, you have a lichenoid eruption, and this is extremely pruritic and may be more difficult to control. So in a case like that, yes, topical steroid can help. You have to often use stronger topical steroids, but you may have to use systemic steroid for short bursts. And also you may have to, let's say, postpone a few treatment, but not stop for a long period of time. This is one of my first and the treatment I've mentioned. Rarely you will have other treatment, but most of the time, topical steroid, moisturizer, and sometimes phototherapy. So I like this here in the table, narrowband UVB. We've used some of that in my patient. Okay. You can have a predilection to develop psoriasis, or sometimes you don't have, and you develop de novo psoriasis. And as compared to lichen planus, psoriasis usually less pruritic, but the more classic extensor surface involvement have been described in the literature. Even nail psoriasis. Actually had a patient with anti-PD-1 treatment adjuvant for very bad melanoma, bad nodal disease in the groin after acral melanoma, and really wanted to stop his treatment because of terrible psoriasis. So this is not easy to manage, and this is has to be recognized. Sometimes you will biopsy that, and it will show lichenoid infiltration, even though it's classic psoriasis clinically. So keep in mind, in immunotherapy, not everything is 100% clear. This is a patient of mine, my worst case of lichen planus. Sorry, it was I should have shown before psoriasis, but anyway, you may even think about maybe palmoplantar psoriasis in a case like that. So we did a biopsy. We had a classic Wickham's tria. The patient had arthritis at the same time. So in that case, we didn't have choice, and we had to treat with systemic steroid when the dose is above 10, 15, 20 milligram. Often we will stop immunotherapy and resume when we decrease the dose of systemic steroids. If we go back to psoriasis, I mentioned moisturizing again. We can use topical steroids, vitamin D. Often we use a combination of vitamin D and strong topical steroid. We can use phototherapy, and my patient, we actually had to go to methotrexate. Was a very good option for my patient and well tolerated, and I was able to decrease the psoriasis and resume by decreasing prednisone and resume immunotherapy for his melanoma. Sometimes it looks like maculopapular, but it's really looking more like eczema. So if you look, you have predilection for flexor. This patient didn't have any history of atopic dermatitis. He was treated for metastatic melanoma, lung and skin. Really wanted to stop treatment, and fortunately was well controlled with topical steroids. And you see, even on the arms, he's starting to develop vitiligo. So in that case, was combination of eczema, eczematous eruption, and vitiligo. Again, I explained family member, the patient, it is important to use a big amount of topical steroid, decrease the long bath. I remember this patient was taking very long bath, decrease, maybe favor a quick shower, and use the moisturizer right after bath. Rarely you will have to use other treatment like maybe a topical crisaborole. Sometimes you will use Protopic or Elidel, but most of the time we control with topical steroid, rarely systemic steroid in this case. And now comes a little bit more complicated and maybe scary eruption, which when you have bulla. So at that time, you really need consult in dermatology. I think you should take the phone and call your dermatologist or send a quick text or email and say, oh, I have bulla. So bulla for us is a sign of severity or more complicated rash. And you have to rule out bullous pemphigoid, which is the most frequent bullous disease in immunotherapy. Of course, in that case, you may be able to control with strong topical steroids and sometimes tetracyclines, but you will probably also need systemic steroids. So this is a nice collection of bullous pemphigoid cases. The classic at the beginning, urticarial plaques, and then you have the tense bulla. It's not the bulla that you will biopsy. You have to biopsy a small vesicle, and also for immunohistochemistry, immunofluorescence, sorry, you will do a perilesional biopsy to find a classic pathology. So This is a patient of mine from Ile de la Madeleine that finally started to develop bullous pemphigoid only in the leg where he had the melanoma, and after that developed some lesion on the trunk. Classic bully. They're a little bit flat here after a few weeks, and the biopsy was giving us this basal membrane classic case of bullous pemphigoid, finally controlled with topical steroids and minocycline after a short course of systemic steroids. The worst, we've seen a couple of cases in every big center of immunotherapy treatment, is Stevens-Johnson toxic epidermal necrolysis. Have been described with both anti-PD-1, also anti-CTL1, either alone or in combination. In that case, you see a very extensive rash, tense, small detachment of the epidermis, Nikolsky sign. This is a patient of mine developed after anti-PD-1 treatment for GU. We could see the mucosal involvement, and unfortunately, we could not reverse the reaction, and we lost the patient for toxic epidermal necrolysis. So there is literature right now coming that those cases may respond very well, or not very well, but may respond well to systemic steroids, either IV or PO. And because now for Stevens-Johnson related to other drugs, let's say to antibiotics like Bactrim, for example, or anticonvulsivant, systemic steroid is controversial and not always used. But in our case, maybe for TEN or Stevens-Johnson associated with immunotherapy, we may go back to the good old systemic steroids in the high dose quickly. And of course, we need intensive care unit, often burn unit, and also consult quickly in ophthalmology to rapid management of the eye involvement. Finally, more in melanoma has been described in a few patients with lung cancer, but classic in melanoma patient, vitiligo can be segmental, can be generalized. You can have the poliosis of the, in that case was the eyelashes. You can have on the lower left what we call halo nevi, actually from the immune system reaction, the nevi are going away. This is a publication, original publication. This is a patient of mine, classic vitiligo. As you mentioned, Marcus, I remember a patient of mine developed vitiligo on the genital area, really wanted to stop adjuvant treatment. In Brazil, we had consult meeting with Brazilian dermatologists and oncologists, and they said it's the #1 reason why people want to stop their treatment, because when you have a very dark skin or dark skin and you develop vitiligo, it's a big social stigma. And another patient of mine developed classic halo nevi on the scalp being treated on double immunotherapy with ipilimumab plus nivolumab. So really, if we want to summarize the management of the cutaneous side effect, first we need a good diagnosis. We cannot maybe in 20 minutes cover everything, but we try tonight to give you like a general sense of some hints to try to recognize severe side effect. Try to be more precise in your diagnosis. Of course, can be maculopapular, the most frequent, but you have to look for specific presentation like lichen planus, and let's say in the wrist, more bluish lesion, flat top, Wickham stria, mouth involvement, psoriasiform eruption. Psoriasis can be more as the extensor, and of course look for bulla, for bullous pemphigoid. When you have your diagnosis, if it's not a complicated case, you could start right away your topical steroid, moderate strength. The key here is big amount. I always tease my pharmacists and say thin layers don't care nobody. Every pharmacist in Canada is putting a sticker on topical steroid, thin layer, don't use a lot. You cannot treat with 30 gram a complete eruption. You need 450 gram, and use moisturizers. Antihistamine, yes, but it's not the main reason. And as I mentioned, we try to reserve systemic steroid for short course only in a second line when we didn't have success. Finally, in collaboration with our medical oncologists, we may have to stop immunotherapy, especially in the more severe eruptions, but try to avoid stopping. This is not sponsored by Taro, but this is the number one topical steroids we prescribe in Canada. Good old Celestoderm, good old Betaderm. 454 gram is the key here, because you need a big amount to cover the large area and big amount for 7 days, and you will cure most of the skin eruption with that, or at least control. Big jar, not 30 gram. 30 gram is good for one application. If you want to use twice a day for a week, you will need the big jar like that. Moisturizers, those are moisturizers from L'Oreal. Of course, La Roche-Posay, Lipicar, Baume AP, which have some products inside to help, some ingredients to help for pruritus. That's what's called AP anti-pruritus. CeraVe is another option. There's plenty of moisturizer, but often those moisturizer with extra ingredients like ceramides or different active products, hyaluronic acid, can help to control pruritus. So really big amount, again, 400 millimeter at least, or at least 250, and repeat the application. So I've tried to emphasize the importance of the daily moisturizing. In the summertime, of course, sunblock and avoidance of big sun. A lot of those skin eruptions can be photoaggravated. I mentioned we can actually have even lupus develop with this immunotherapy. Avoid irritants, decrease long bath, and really it's good for male to have good teaching, because male are not good to moisturize, women are better. Finally, to summarize before we do the post-test, is immunotherapy is fast growing and almost in the most frequent used treatment for cancer patients, especially lung cancer and melanoma and GU. Many publications have described the side effect of immunotherapy. Skin is one of the most frequent touch organ. Pruritus, psoriasiform, lichenoid, eczematous, bullous, pemphigoid have been described in the more specific eruption, and you need a good awareness of physician and the healthcare providers to diagnose quickly and especially detect severe eruptions. Let's go back to the poll, and maybe we have 5 minutes for discussion. So what is the less frequent side effect of immunotherapy in cancer patients? Answer? So now you get the good answer. First you said skin, so it's not true. I would say skin is probably the most frequent with colitis and this thyroid dysfunction. Often skin is overlooked, can be up to 40% in some studies, and cytopenias can be severe, but I would say pretty rare locally. Next question. Pruritus is frequent side effects of immunotherapy, true or false? Quickly. Answers, you had it right first, you have it even more, 93%. So I would think that's something we forget still. I think in your cancer center, if you could actually instruct your patient to decrease the big long bath and decrease use of soap, use gentle care, and moisturize would be great to prevent that. Next question. What is the most frequent cutaneous side effects of immunotherapy? So you got the answer first was maculopapular. Let's see the answer now. Maculopapular, yes. I would say the most classic, most classic is lichen planus or lichenoid eruption, which is pretty frequent, and the rare ones, of course, we can have psoriasis, bullous pemphigoid, and vitiligo, as I mentioned. But the maculopapular one is the one probably we don't need to see as a dermatologist and can be managed by my colleague. Look for mucous membrane in Ebola for severe. And finally, the last question. What is the most important aspect for treating cutaneous eruption? Looking forward to your answers here. Answers: topical steroid, yes. Not a 30-gram tube. You have to specify to the pharmacist and see if you don't want to be criticized. Write in your prescription in a big amount for 1 week. You don't need to use steroids for months. Use for 1 week and then you go back to your moisturizer. Maybe we open to chat and question. I hope it covers the topic. Do we have any question in the chat?
So thank you so much, Dr. Claveau. Again, if you want to submit questions, use the question chat pane on the right-hand side of your screen. And if you think of any questions afterwards, you can always send them to info@rbcconsultants.com. Again, we'd like to thank our sponsors, La Roche-Posay, Laboratoire Dermatologique, for making this educational event possible. So we do have a couple of questions from our audience. The first is, we're seeing more combined chemotherapy and immunotherapy. So are you seeing different types of skin toxicities with this combination or the same as with immunotherapy?
Yeah, the answer is Marcus and I both answering at the same time. More and more severe, especially with ipilimumab and nivolumab. I would say the main treatment right now, like the gold standard of treatment, especially for young fit patient, is using ipilimumab plus nivolumab. We get up to 50–55% survival at 5 years, even now 7 years and a half. And we see a lot of skin rash, and you can see the more severe. As mentioned by Marcus, we will have new combination right now with anti-LAG3 and anti-PD1, and probably the side effect will be less severe, and we hope we will not see too many of those TEN and Steven Johnson. Any comment, Marcus?
Yeah, and there are other combinations with targeted therapy. Also, if patients have had immunotherapy and they're switched to targeted therapy, often you can see some severe rashes occur due to the targeted therapy. You get them through that. On targeted therapy, we often will use systemic steroids to settle things down because we're not worried about the immune response. And then later on, they no longer have the skin toxicities with putting back on targeted therapy. I was wondering, Joelle, the lung cancer doctors are using a lot of chemo, traditional chemotherapy plus immunotherapy. Are you seeing different skin rashes with pemetrexed, for instance, plus pembrolizumab and those sorts of regimens?
I would not say yes. I don't have a big lung group in my hospital, but I would not think not too many. It's really P-niveau. But more and more, my med-onc guys are managing it. That's great. So I see less. I see the stranger one, but we've seen plenty of strange reaction, paniculitis, sarcoidosis, classically described, arthritis associated with rash. So really, it's the importance of multidisciplinary approach. I have a question for you, Marcus, before we have. At which dose do you try to stop your immunotherapy of prednisone, like above 10 or above 20?
Say that again. At which dose do I restart or?
No, but let's say if you have to give a prednisone for colitis, the time we tend to stop immunotherapy and you will decrease your dose, at which dose you will restart your treatment.
Oh, I see. Yeah, it really depends on how, it depends on the patient. If the patient has had a really good brisk response, but really bad toxicity, I might just wait for them to be off of steroids. In cases where patients are definitely having evidence of progression, I'll probably, and their toxicity wasn't that difficult to control, I'll restart them on immunotherapy when they're still on steroids at 10 or 20 milligrams of prednisone per day. But yeah, I don't think there's any single correct answer on this one. There have been cases where patients have basically no other option, but they'll develop some sort of immune-related toxicity that's sensitive to steroids, so that we'll actually use both steroids and the immunotherapy, and we're able to avoid severe toxicity. So it honestly, it has to do, in my mind, with what I think the risk is of their cancer.
Great.
Okay, we have a question from the audience. Could you please explain the mechanism whereby hair and nails are lost with some cocktails used in treating cancer?
Nails I haven't seen. Hair, I've seen a couple of cases of alopecia areata and alopecia universalis. Actually, a patient of mine, I should have shown the picture, regrew. She was on Epinivo. She lost all hair, all eyebrows, eyelashes, and she's a survivor, and she's regrowing hair. So very happy for her. I've seen a classic alopecia areata on hair, so spots, recently. Nails. I haven't seen any nail eruption, but probably have been described in nail psoriasis. What about you, Marcus?
Yeah, that's more of an issue with chemotherapy-related toxicities, where you have nail damage due to chronic chemotherapy use. There are some, occasionally patients will have pitting psoriasis that results in some nail changes, but other than that, the nails are usually reasonably well preserved with the immunotherapy-related toxicities.
Good question, thank you.
How do we counsel a patient with melanoma being placed on point immunotherapy if they've had multiple skin fillers in the remote past, more than 3 years ago, or if more recent?
I haven't seen any publication on the fact that if you have fillers, you have more chance of developing problems. Of course, with fillers, you can have granulomatous reaction. So I suppose one day we'll have a case of increased granulomatous reaction to the fillers, or maybe tattoo. But what I've seen mostly was sometimes you have a sarcoidal reaction in the lung with immunotherapy, and I've seen some skin lesion associated with that. What about you, Marcus?
Yeah, I've never seen a major issue in that case. I think there was, in terms of skin manipulation, there was one case that we had of a patient who had a very strong immunologic reaction to the tattoo dye, where the patient had a rash that kind of outlined the area of tattoo, and then that resolved with steroids. But I haven't seen any issues with fillers.
Another question, thank you for a great talk. Have you ever used Enbrel or cyclosporin in the SJSTEN group?
No.
Yeah, do you think that would be of help in a case, or no? Just high dose steroids?
Probably be afraid of using cyclosporin in a cancer patient.
Mm-hmm.
It's still not clear, but there is a little bit of literature recommending using steroid might work better than the classic TN or Steven Johnson, which is good.
To what degree does a patient's stress reaction to the diagnosis of cancer exacerbate the skin eruptions? i.e., is there a role for counseling?
I'm usually a dermatologist that said that stress doesn't give skin lesion. Of course, can worsen. Classic is atopic dermatitis, eczema. If you have an exam or you have a problem at home or at school or anything, you will worsen your skin. Also psoriasis, but those are the two conditions might be worsened by stress, but really in those reaction we've presented tonight, it's really immune related. Biopsy, we've seen the inflammation with lichenoid eruption, lichenoid influx of cells, and really it's an immune mediated process.
I think that's a interesting question. It's probably understudied, as sort of mind over matter issues often are. It would be interesting to see if, for especially eczematous type of toxicities, whether that may, it's so hard to tease out whether the immunotherapy or the stress of having cancer and being treated for it is involved here, but certainly a worth considering in patients. By definition, all cancer patients are under stress, and there have been studies that psychological counseling is beneficial for everyone. Unfortunately, the healthcare system does not provide that benefit, but there we are.
Yeah, but it's a big field of the psychological care in cancer patient, and we know that if they can relax and do yoga and eat well, it's always good. So I think, as you mentioned, in cancer center, we are often concerned about giving the treatment, but we don't address this issue frequently. But one thing we should avoid maybe a natural food and natural products can worsen skin rashes sometimes. Okay.
So that is all the time we have together this evening. I'd like to thank Dr. Joël Claveau and Dr. Marcus Butler for really an interesting presentation, very enlightening, and sharing your knowledge with us, of course, to help cancer patients in Canada, everywhere. And we'd like to thank everyone in the audience for joining us this evening. Good night, everyone.
Good night.
Roxanne, and thanks, La Roche-Posay.
Yes, thank you. Bye-bye.
Bye-bye.